And now, as I briefly mentioned while the start, and I'm sure as few of our speakers, sir, have very frequently mentioned that we are launching VOH Incubator today. Voice of Healthcare is taking the opportunity of this platform and this amazing gathering to officially launch the Voice of Healthcare Incubator. To grow and blossom, a founder's vision must meet the experience of mentors, the on-ground wisdom of practitioners, connections with like-minded peers, the right talent and the attention of both sharks and angels. This is exactly what VOH Incubator is intended to achieve. It's a brainchild of veterans and visionaries from the healthcare space. VOH Incubator is designed to help healthcare-focused and to connect the dots that can solve pressing, contemporary, and future challenges of healthcare and innovate novel solutions altogether. With that, I'd like to request a short introductory video on our screen, please. With that, for the introductory remarks, I'd like to call upon on stage Dr. Naveen Nischal, the main brain and the man behind VOH Incubator. So please come up for the introductory remarks.
Thank you very much, Khushbu. I think it has been a very long day. And thank you very much for your patience. Thanks for being engaged. And I'm sure today we had some, learning session, wonderful speakers. And the most important is we have a wonderful audience as well. Thank you very much for being part of this event. So officially, I want to again welcome you all for Voice of Healthcare Incubator launch. VOH Incubator is our latest initiative amongst a couple of more initiatives. Like, you know that Voice of Healthcare is a healthcare industry connect platform where we talk to all the stakeholders of healthcare industry, be it providers like hospital diagnostic center, pharma, medical device, health insurance, health tech, and much more. For this incubator, we started our journey in the month of January, and all the mentors are closely working with this VOH Incubator. We had a couple of meetings and we conceptualized the exact nature of this VOH Incubator and started working on building this incubator. So during this journey, we received very exciting and fantastic response. We received 106 applications, out of which we had a couple of rounds, some domain rounds, and we selected 3 startups for our first cohort. Our applications are still open till 31st May. We want to add 3 to 5 more startups. So for the first cohort, we are planning to have somewhere between 5 to 8 startups. So if some promising startups are willing to become part of this journey, we are happy to have them on board. So I'll take a step back and I will talk a little bit about philosophy. Even, for last couple of years, my philosophy about startups has changed. I mean, it has changed from building bigger startups to building impactful startups. So our thesis at Voice of Healthcare Incubator is impact. If a startup is creating impact, we are there to support them. We are there to help them. And when I talk about impact, this morning also I spoke about impact. I remember when I was building my first venture, Cygnus Hospitals, and a lot of my colleagues from Cygnus are also here. So I created 10 hospitals, and in these 10 hospitals, I touched 70,000 patients every month, 8 lakhs patients every year, and so far I have touched almost 4 million lives. A lot of people say that this is an impact. But I tell them that after our success, a lot of other players, they also started venturing into tier 2, tier 3 cities. So now there are more than 20 players, 20 healthcare chains working in different parts of the country and having hospitals in tier 2, tier 3 cities. And that is the real impact to me. So with that, I would like to welcome all 3 startups on board. And all these 3 startups need your blessings and your support for future. Thank you very much. Thank you.
Thank you so much, sir. I'd now like to call upon Mr. Tarun Agarwal, the mentor of Voice of Healthcare Incubator, for a welcome address, please. Can we have him with a round of applause on the stage?
Hi, it's been a long day, so we'll keep it short, and I'll not come in between the startups, which is, I think, the highlight of what we are trying to do now. I just want to add that Voice of Health Incubator is something very, very exciting to me. I have been part of the startup ecosystem for quite some time, and I believe that this is India's first attempt to have a healthcare-focused sectoral incubator. And healthcare as a space is complex with its own, let's say, nuances and challenges. So we at Voice of Healthcare Incubator are trying to help startups in this space with these specific, let's say, challenges that they will probably encounter in their journey to scale up in the healthcare space. To me, that is something very value-adding and impactful. And that's what excited me to kind of work and help Naveen build this incubator. So congratulations to the startups who have made it to the cohort. And as Naveen said, we are still open for the next couple of weeks to kind of, in case anybody else is interested. And then we will kind of get down to work and start helping scale up. Yeah. Best wishes and thank you.
Thank you so much, Tarun. With that, I'd also like to call upon Mr. Rajiv Nath, Managing Director HMD and Forum Coordinator AMET, to please come up and share your opening remarks and best wishes for the incubator. AMET is also one of the supporting partners of the incubator. Can we have Sir with a round of applause, please?
Hello, everyone. Exciting times indeed, and very happy to see VOH has progressed from just being an informal forum at one period of time to becoming a more formal conference to a day now when it's become not just be a mentor of one startup, but creating an ecosystem and being an incubator for multiple startups, starting with 3 today, and many more to come from now on. Many of you may be aware of the launch of the Make in India national policy. The notification came out yesterday, and this is something that we've been waiting for a very long time, when India can move from an 80% import dependence and have a real Make in India program like we have in the pharmaceutical industry and many other sectors, and reduce the imports coming into India and help healthcare providers access low-cost medical devices made in India with high quality. And with this policy coming forward, hopefully the medical devices will be now available not only for the Indian market, but also for the global market. And with the policy in play and the strategies in play, if the government, 20 departments now, they have a beacon light and the direction to take, with that advantage of uniformity of direction, hopefully the 6 strategies which the government has spelled out. Number 1, of streamlining regulations, hopefully into a separate medical devices law. Inviting investments as a second component, which will helpfully be used to correct the tariff structure so that it becomes viable to make medical devices in the country rather than importing them. Number 3, to encourage use of innovation coming in from various startups and developers into the ecosystem by having a decriminalized law like we put in the Food Safety Act, and by upskilling and reskilling professionals and reviewing academic courses. And this upskilling especially is required for our regulators, most of whom come from the pharmacist background as drug inspectors, now being asked to look after medical devices. So they need to be retrained and re-educated and think not like pharmacists, but as engineers, not from the point of QC, but from the point of QA, not quality control, but quality assurance, to help manufacturers take products forward. For startups and the incubators, what we've seen for Make in India in the last 10 years is a fantastic ecosystem that is evolving, especially in the last 5 years. Venture Center in Pune, IKP Knowledge Park in Hyderabad, C Camp in Bangalore, Medi Valley and Bio Valley in MTZ. Nearly 80 bio-nests all over the country, a astounding figure. The various IITs having their own centers over there. Plus, you've got additional initiatives like VOH today over here. When I joined my company in 1984, Hindustan Syringes and Medical Devices, we make Dispovan. It was a very far cry of the ecosystem that time. And pretty much to make any product was like climbing a wall. Just to innovate and move from glass syringes to disposable syringes, and making sure disposable syringes are used one time and not multiple times, not being boiled and being reused, took us more than 15 years of selling the concept. Now, of course, changing times, but even with changing times, it's still a challenge for startups and entrepreneurs to sell innovation in India. Many times, the medical profession will voice a need. Engineers, doctors, developers will hear that need and convert that into an idea or a product. When they go back to supply that need or market and product, then they find a shifting of the stand. So what they heard initially and what the buyer now wants is completely different, especially when he hears the price and the value of the service delivery or the product. And the entrepreneur or the developer has to then, again, slightly modify his strategy or bring in the finances and go forward. And this becomes a crucial time for an idea to go forward or to be killed. I would recommend to all startups, be patient, be focused. Perseverance is what's important. And just don't go chasing money for the sake of chasing money for scale up. Success comes step by step. And sometimes, unfortunately, what happens is you may need 1 crore to actually take off. But sometimes it's easier to apply for 50 crores and get that 50 crores in today's world. Because 1 crore is too meager for a large financial outlay. For a big size company, for them, it is too meager an amount. They would rather fund a bigger project. So consultants will help the company to show projections not at a country level or the state level or regional level, but at a global level, even though the organization may not be ready for it. And then you have a huge influx of funds, and you do not know what to do with the money. And then you use that money not for your original project, but then to buy up other startups and other companies and other projects. And this distracts you from your original goal. And you end up chasing other people's dreams and not your own dream over there. So, just a friendly reminder to all of them, be focused. It's good to be ambitious, but don't go chasing such dreams that you falter in achieving your own dream over there. From IMED, our Association of Indian Medical Devices, any entrepreneur, any startup who's not making a medical devices yet can use our platform. We've created a forum called UdayMed. UdayMed, Uday is sunrise. So U for user, D for developer, A for academia, I for industry. That is interfaced with the various government departments, whether DST or DBT or BIRAC, and the various academic institutions. And once you get on our email listing over there, you'll be able to get emails regularly on a daily or a weekly basis about what's latest in the evolving ecosystem for medical device manufacturing in the country. You'll be abreast of the latest notifications, the latest laws, latest regulatory changes, as well as policy changes which will be impacting your journey. One may wonder that how policy is going to affect you. Policies are something which create the ecosystem and that can impact the growth of the smallest to the largest. So it's always good to be abreast of what is happening as the latest. Conferences like this keep you, of course, updated. So keep yourself informed. And we hope now that this new medical devices policy is going to be into play. More than anything else, this is going to be something that's going to be helping the startup ecosystem go forward more rapidly than even before. So more acceleration will be available. Use it to your advantage. Thanks very much. You can always reach out to us at IMED. Just Google us and you'll find our email ID and you can go to the website and join up for free over there. Thank you so much.
Thank you so much, Mr. Rajiv. Sir, I think that your words of wisdom might have a lot for our startup minds to take home too. Now, to bring this event and the grand launch together, we at VOH, with our set of mentors, advisors, and partners, have been tirelessly going through the applicants of our incubatees, and after a thorough process of technical screening in stages, We'd like to introduce you the first cohort of VOH Incubator who would be with us and presenting their ideas to you. Welcoming our first incubatee, Semper Centrum, to the stage, please.
Thank you, VOH. I am Manmohan Singh and would like to talk about Semper Centrum. We are working for last like 3-4 years on the idea, and one of our achievement is about that we refined our idea, which we were explaining like in 1.5 hour. Now we can explain in 8 to 10 minutes. Still, we are trying to make it like 2 minutes. Other than we have a very refined product with us. So Semper is the word rehabilitation. We started working on heart attacks. COVID-19, there is one problem which keep on getting discussion on all bigger forums is heart attack among young ones, unpredictability, and this problem came into like quite prominence. We started working on this prediction part. Cardiac rehabilitation is one intervention which is something can reduce the chance of heart attacks and all. In that journey, we find some sort of wisdom, and that is something I'm going to explain here, what it is exactly about. So before explaining our idea, our product, anything, I'm going to tell you certain statistics. And because as a layman, we have a lot of problem in understanding predictions, and that is something I'm going to make easy for you. Unfortunate thing, we do not have data in India, so I'm telling you statistics of USA. A country with 32 crore population, 8 lakh heart attacks every year, which is 0.25% of their population. The probability of having anybody heart attack is 1 by 400 person years. Can you predict it? Whatever you say, AI and machine learning and anything, no. Now I'm giving you another statistics. Out of these 8 lakh heart attacks, 2 lakh heart attacks are recurrent. The rate of recurrent heart attacks is close to 25%. 1 out of 4 person who have first heart attack going to have second heart attack or cardiac death. Can you predict it? Can you predict this? 1 out of 4 or 1 out of 400? So the probability of predicting secondary cardiac events, secondary heart rate attacks are much more than predicting primary or index or first heart attack. This is where exactly we are working. We are building predictive model for predicting secondary heart attacks. Now the second thing I will come to, is there any point to predict something which you cannot prevent? No point. So we are building a preventive program around it, which is cardiac rehabilitation we call. We are creating a digital version of it. It will be a digital cardiac prevention program. Now the another point is there a point, can you prevent something which you cannot predict? All these are the problems in the healthcare. They say, if you go to a cardiologist who has done angioplasty and you say your patient might survive 1 year or 2 years, 3 years, they will say, no, he's doing wonderful, but I don't know when, how much and whether they will survive or not. We are correlating all these links. So data you need to predict, prediction you need to prevent. That is what we are doing exactly. So our vision is building world-class digital therapeutic products for preventing secondary cardiac events and heart attacks using big data analytics. So what is the gaps? One gap is we do not have data. I have cited American data. I don't know how many heart attacks in India. They say 3.3 million. But if you project American data, it will be 4 million close to. But we have no data on secondary heart attacks, which might be 1 million in India. And there are interventions available, this cardiac rehabilitation, as effective, it can prevent 50% of heart attacks. It means in India alone, we can avert 5 lakh heart attacks. But we are focusing on something which is primary, not secondary, which is easily predictable, where baseline population is very well defined, where intervention is very well defined, which can have impact on secondary heart attacks. So 3 things: data, prediction, prevention. For the data, recording, we have created a world-class product. It is HIPAA compliant, it is GDP compliant. We are taking care of good clinical practice, GCP. It has 21 CFR 11 compliances. And this product, we are recording, so we call it e-registry platform. Its name is Curiosity. We are collecting all comprehensive longitudinal outcome-centric data, which is required to build this product. It has demographic, clinical data, your anthropometry, your genomics, everything about your imaging data, your radio diagnostic data, and more importantly, follow-up and outcome data, without which you cannot say this intervention is effective, this disease is what its impact going to be, whether disease, whether intervention, whether prescription, whether medicine. And so out of this data, so one product, registry platform, then we are going to build cardiac digital therapeutic product, and this platform will also be work as a clinical intelligence platform for healthcare providers and other stakeholders in the industry. So we are already have this product, and we have installed in more than 10 centers. We are collecting some wonderful data in cardiology. Probably in India, it is something never ever have been recorded in this detail. In some registries, we are recording more than 400 variables for one patient. This is a SaaS-based platform. We can run multiple registries. We can run multiple registries across multiple departments. We follow GCP guidelines. It has features like remote data monitoring. Quality assurance is one important part in data. So when we say real world data, as we say garbage in, garbage out, that is something we are ensuring that we record highest quality of data, where we can build the best prediction models and can take to agencies like FDA. We are HIPAA compliant company. So now in cardiology, most of our registries are in cardiology space. We are almost capturing everything, in whether it is hypertrophic cardiomyopathies, whether it is heart failure, whether it is MI, whether it is premature deaths because of cardiac reason, whether it is premature coronary artery disease. So we have registry almost in all space. What is our advantage? If you want to install a registry at your institution, it will cost you close to 1 lakh US dollar, somewhere between 50 to 80 lakhs. We are making it very, very low cost. It is world-class compliances we have. And more importantly, when we go to India and we talk about data, then everybody fear what they will do and all that. We are taking care of those compliances very seriously. So from the beginning, patient confidentiality, patient privacy, everything can be ensured. Healthcare providers can have confidence in us that their data is safe with us. So that is all. We are working on this. This is our team. So any question, any query, please. Yes, sir. So I think one thing which we struggled in last 2-3 years, when we say anywhere, we go to pharma, we go to anybody, they say doctors are not interested in research. This is very counterintuitive. Almost every doctor is interested in research. What they do not have time. If somebody is doing 2-3 angioplasty and taking care of a OPD of 100 patients, definitely they are not going to have that sort of time where they can do this. Our proposition is that we will do everything. You just tell us objective. We will create CRF, we will create protocol, we will implement it, we will digitalize this data, we will ensure that our CRA reach to your facility and record best quality of data. And then we have features in the product like remote monitoring and everything, where we can ensure that each and every day the data which is coming in the system is of the highest quality. But adoption rate, especially in subspecialties like cardiology, oncology, I would say it is good. That is, I'm saying from the healthcare provider perspective, not from the product perspective. We are still 6 months to 1 year away from first cut of this digital therapeutic product.
Because I have seen, most of the medical schools, they don't teach all this, and I have seen always a tussle, anything which comes good, it takes really long time, in terms of doctors, physicians, taking something which is high tech, so and you're doing fabulous job. Keep it up.
Thank you, sir. Any other question, query? Yes, please.
it's a fabulous thing.
Thank you.
I just want to know, you seem to be collecting a lot of genomics data as well.
So this is, yes, please complete your question.
So I'm just wondering, like, how easy it is to profile genomics data. Is it a microarray or a WES sort of a data?
So
that
one
you're
of my
collecting?
co-founder, he's taking care of genomics
Yeah.
and has experience of like 20 years. He would like to.
Good evening. So most of the data we are running on GSA, which is the Illumina platform, and we are collecting almost 6.5 lakh markers. I mean, this is a chip which has been used across the globe for the validation, clinical use, and also for the research. And all the data which we have generated is genotyping data. And there is a very strong section of cardiology where we are not only looking at the prediction and a predisposition of genetic markers towards the cardiac and cardiometabolic conditions, but we are also capturing all the drugs which are being prescribed for a cardiology patient. And as per the guidelines of FDA, CPIC and ACMG, we are also collecting that data. And of course, I mean, on the diagnostics part, we are covering that. So basically, we are just using the genomics for the first level of correlation. And we have already built certain very good insights wherein we have seen that whatever the responses to certain medications like antiplatelet or antihypertensive drugs or even the statin myopathy, the stats are entirely different from what's been present in the Caucasian or Mexican population, or maybe when I say Asians, we are a little different from the actual Asia. We all are aware of this. So whatever the data has been generated in Korea or Japan or in China, we as a India, we have a very less representation, but we have the last couple of years we have spent a lot of time and efforts on bringing out Indian genome data, especially in the cardiometabolic space.
So once your product comes in market, how much cost would go to the consumer or the customer or the patient in getting all this data screened for getting any prediction from you?
So we have like these two products. One is purely for healthcare providers where we are recording data. And as I mentioned, this is very, very low cost in comparison to what market is offering. Like it is like we are offering it at like 10% of the cost other companies are offering. When we are talking about the cardiac digital therapeutic product. So if you see the cost of cardiac rehabilitation, it is approximately should be close to 50,000-60,000 rupees because it requires real time monitoring with ECG and a number of exercise sessions like 24 to 36 sessions. That is how they do it in USA. In India there is no program. It is like 90% of cardiac patients after angioplasty get no rehab at all, no exercise sessions or something. So these are 9 to 10 risk factors as mentioned in inter-heart studies which need to be taken care of after angioplasty, which can reduce the risk of secondary heart attacks like by 50%. Why we are building digital therapeutic product in this space and why it can fulfill this felt need. The reason is, let's say somebody is undergoing intervention in AIMS, New Delhi, and that patient is coming from Meerut or Muzaffarnagar. Can this patient come to the AIMS again every week for exercise sessions? That is facility-based cardiac rehab. So facility-based cardiac rehab, at least in India, has no scope. Then another thing is business proposition. If I say, ask a cardiologist to have a cardiac rehab center, cath lab is much better business proposition. Why not to do more angioplasties rather than have a cardiac rehab thing? Even in US where it is covered by insurance, uptake is hardly 25%. So this is the space where a digital therapeutic product can help, and the experience during this pandemic is like this. They are saying that home-based cardiac rehab is much better than facility-based, and adoption rate is high, and it is low cost. So we are expecting it to be like somewhere between 10,000 to 20,000 rupee per patient, which might reduce cost by like 40-50% from the actual cost.
Thank you. Thank you.
I have a question for you. Fantastic work that you are doing.
Thank you.
So mostly I think you've already done the hazard analysis and the regression analysis, etc. And it is mostly based on the genomic genetic polymorphisms, etc.
Yes.
Now, what we have seen over the period of time that infections, especially viral myocarditis, etc., are so underreported and they are one of the major causes of the morbidity as far as cardiac cases are concerned. So, like we have seen in this case, immunomodulatory effects of the vaccines in COVID time and the viral myocarditis. So, how are you kind of inserting this particular data, especially in the young people? Post angioplasty, of course, is a different
Yes.
issue altogether,
Yes.
because I guess sepsis and infectious diseases, especially viral diseases, are one of the greatest killers, which you have to include into that. How would you do this?
So, like when we are taking these registries and interacting with cardiologists and research institutions, there are a lot of insights and wisdom coming from them. Like it is a common thing now. They say that there are a lot many patients who are coming with cardiomyopathy. There are a lot many patients who are coming with premature CAD. And this myocarditis thing also mentioned somebody, very prominent cardiologist. Uh, what we are doing in all registries, we are capturing very significant granular details about COVID-19, like detected, not detected, vaccine taken, not taken, and if it was COVID-19, whether it was managed at outpatient level or inpatient level or ICU, how many days you were in ICU, whether steroids were given or not. That sort of details we are recording in certain number of registries. But at genomic level, nothing much, but we are recording these variables.
Thank you.
Yes, sir.
Yeah, I think the go to the market, what you indicated as cost about 10 to 20,000. So do you think that, I mean, what is the scale to which it will be adopted, considering this as the price point?
So our idea is, let's say if angioplasty take X cost and cardiac rehab can be added on it like 10% of the angioplasty cost, which is close to 1 lakh rupees, somewhere 1.5 to lakh. It varies in 2-tier cities, in metro cities. And if we can club it with this. So what I find is like I visited like 20 centers for cardiac rehab, having sessions and all that. So there is one is patient perspective, whether they want to pay or not. But patient perspective is secondary. The first primary perspective is of cardiologist, if they see value in this. So what is happening in like in this space is most of the programs, they don't touch hardcore medicine. If it is like weight management, but if you say dyslipidemia management, nobody want to touch it like that, because it is a space of doctor, and then there is a fear that we are breaching that line. What program we are building is will be more medical program, research based. That's why we need evidence. So we need evidence, we need FDA. That's why we are building that much data, because this sort of program already, there are so many programs in Western world, they are there, we can copy and paste that. But until unless we do not have evidence, like I have met like hundreds of patients, and we think in India that obesity is such a huge problem. I can tell you there are patients who walk marathon, who were tall, slim, have heart attack before 40. What is the explanation for that? So our idea is, and see, in India we get heart attack 1 decade earlier than Western world. We have much higher mortality rate. Secondary mortality rate, if somebody gets second heart attack after first heart attack, the mortality is 50%. It is very, very dangerous. There are certain, that's why it will be an Indian specific system. That's why we need data from India. Whatever we are following, Framingham or Interheart study, which is all this work is happened in Western world. We do not have what is happening in India. We say in rural world, but I have met hundreds of patients who say I do agriculture thing every day, still I have heart attack. So I think we need those local insights in India. Probably then we can make more accurate system. Might be we are saying we have to manage obesity, but I would say we have to manage depression and stress more. And might be we are undermining stress and obesity. The problem is stress and depression in rural India, but it might be more than urban India. So because there are a lot of assumptions which are not supported by data. That is something we are trying to create.
So just to add on the cost. So we have these models where, so we have a software or the digital therapeutics product, and then there are elements of diagnosis, wherein the imaging and the genomics may be a little on the expensive side. And then comes your care program. Now, as on today, when we are trying to build this model, of course, we cannot bring it down as low as possible to make it affordable. But as the volume increases, I mean, in fact, I'm just taking an example of genomics. If I have to do the same run which we are doing it 2 years back, it used to cost me around 25 to 30,000 rupees, which has come down to almost 10 to 15,000 rupees. Now, as we build these models, and then we have a little more authentic and validated markers, we can bring down the price to like 3,000 rupees. And ECGs and the software which we wanted to build and install to run the initial level of data capture and build the validation, we have taken like what, I mean, 7 to 8 quotations. And the lowest cost for these licensed software was 35 lakhs, the lowest one. And the expensive one actually gone beyond 150K US dollars. So we have built, in the last 2 years, we have built our own software. And we think we can, I mean, of course, India is, for the software skills point of view, we have utilized that. And what it is sold at 60 lakhs or 70 lakhs, we have bringing down to almost like 10 lakhs or 15 lakhs. So we also understand that in India, affordability is the key thing while we are trying to give the same quality and services and the value on the solution. So it's very much possible that we can bring down below 10,000 or maybe below 5,000 in just 18 months to 24 months.
That's a good point that you made. I mean, I am just saying that the variable that is more typical to the Indian population is the health-seeking behavior. And have you captured that? Because health-seeking behavior is different in our context, and that too for the palliative care. I guess post episode, care, people just get well and then they probably forget everything, and anything spent after that is considered to be a burden actually, even if one can afford it. So has this element been captured into your algorithm?
Just wanted to add why it is very important to have a very specific local population-based data. I'm just taking an example purely from the genomics point of view because we have this data in which we have published data also. So when we look at all these patients who undergo angioplasty, they've been on antiplatelet. And the antiplatelet non-responsiveness or poor metabolizers in Caucasian population is only 9%. That means if there are a million patients, I mean, only 9 patients out of 100, they are a poor metabolizer. That means they're taking this antiplatelet, which they are not able to metabolize. And that is one of the reasons why there's a recurrent event with the cardiac patients. Now, when we run in the Indian data, I mean, when we have run it on almost 2,000 patients in the last 1 year, we are seeing the percentage is over 35%. So we as an Indian, we are predisposed to a very low cost clopidogrel molecule. It's a low cost. Also, we are a poor metabolizers in terms. And that is also a big reason for recurrent MI. This is one of the reasons. I'm not telling that this is the only reason, but this is one of the reasons. I mean, this insight is such a key insight. If we add this as one of the parameters in our whole algorithm of prediction or recurrence, it gives a lot of weightage in better prediction. So that gave us a motivation to actually start building the data on the ground and build a high quality data.
So one last question, if I can ask.
Sorry, on the
So-
health-seeking behavior side, what you asked, the health-seeking behavior part at least becomes a little more, or people are, more open to it once they've had one event. So, primary prevention, of course, is even a lot tougher. Even if somebody has a lot of, let's say, predisposition or risk factors, etc., that's a lot tougher. But then if you've had an event, you're a lot more open to, and seeking help to ensure that a secondary event doesn't occur, and especially if you're given statistics, if there's awareness. So a lot of our digital therapeutic product is based on driving awareness among the population, because unless you're aware, you're not going to really kind of, imbibe that. And we saw a lot of that also when we were looking at medication adherence. So a lot of times, when people start feeling better, they'll stop taking their aspirin, or they'll stop taking, some of the statins or whatever it is. But if you tell them what it's doing, that even if you're feeling well, you need to continue to take it for this reason, that helps the patients to, continue with that better behavior.
Yes.
that's a valid point. I'm saying this is as far as the consumer, ultimate patient is concerned. But the challenge, of course, will remain the same, which probably Dr. Manmohan Singh, you must have felt that it is all driven by the physician. So, are you actually capturing, changing the the mindset of the principal actor?
It will be difficult. Even it's not patient who is the biggest hurdle in taking cardiac rehab or these interventions. In US, the information is like this, that cardiologists do not prescribe this. This is another burden on them. They have to stratify risk and they have to take many more responsibilities. But I think because I talk to patient directly, I understood that it is something needed. They understand it is needed, but nobody explain. And in India, it is not about the quality of program or anything. We don't have program. It is absent absolutely.
It's a very long debate. I think Dr. Prasad, you would also agree with me. We have a challenge of the AMR actually. Now I'm sure what I'm saying is something which is a bigger problem. And I think this behavior change is a very big challenge.
It is.
Yeah, I mean, we totally agree. I mean, when we actually we look at the example of the behavior, seatbelts was invented in 1920, and the actual law came in to make it mandatory is after 100 years. Even though we know that it saves lives, it still took a century to make it a mandatory. So we are doing our bit. Let's see how it goes.
Yes, please.
Yeah. So with your proposed plan, you can collect a lot of genomics data, which will be sort of a rare thing. So that means that in the near future, once you are able to find the correct genomic biomarkers, you can also move into the precision medicine, not only for CVD, but also for other disorders or comorbidities that the patients might be suffering. Am I correct?
Yes, certainly yes. So it's not only for the certain conditions, but we are looking at the complete array of conditions, from myopathies, hypertension, response to drugs, how the nutrition actually playing a role in this. So while we are collecting the data for a very specific objective at this point, but we are building a very, very powerful data at the back end, which can, when we start connecting the dots, it will certainly give a very powerful insights.
Well, thank you. Thank you so much to the audience. Thank you so much. Okay, they'll have to do it. I think you want the last slide where their contact information was there. But anyways, thank you so much, Team Semper Centrum. All the very best. Or maybe you can, yeah, sure, we have the slide. Well, with that, I'd like to welcome the second incubator, the second startup by the name of Foundry. Can we have their presentations on the screen, please? The team is in Chennai, so they'd be presenting from there. Can we have Foundry's, yeah.
Greetings, everyone. Thank you very much, Voice of Healthcare, for giving us the opportunity to present today. I am Tulasi Raburi, the founder of Foundry Medical Technologies. Foundry Medical Technologies is a Bio Valley, Andhra Pradesh medical technology incubated company with collaboration between USA and India teams. We have a global team of medical, mechanical, electronics, software, quality, and clinical professionals from leading universities and industry in India and USA. Our aim is to build high-quality medical devices, currently pursuing respiratory devices. The main products this year that we intend to introduce are the ventilator and the powered air purifier. Now, most of you might have a question on your minds. There are so many ventilators in the market. What makes you different? So the main differences from our perspective are it's a lightweight transport ventilator that one can carry both from the field to ambulance to the hospital. And it can go from adult to pediatric. And a bigger difference that we see, most of the ventilators that are made in India are either assemblies of various major components that they've acquired or air compressor driven. Our design is completely our own, from the pneumatics, software, user interface, the PCBs, the mechanicals, everything. And we aspire to take it all the way to FDA and CE certifications. The second product is the powered air purifier respirator. From what we've researched so far, we haven't seen any PAPR makers in India. So that makes us unique. And the target pricing is about half of the cost of the imports. And it bundles a full face mask. So whereas with the other products, you have to procure the full face mask separately. And to complement these two devices, we have a monitoring device which can plug in between the ventilator and the patient, collect the data and upload it to the cloud so that one can monitor this ventilator, a group of ventilators in your organization. And also a little device that goes into your full face mask for monitoring the all the air aspects within the mask. A quick view of our financials. We have spent about 4 crores so far and valued at about 40 crores for all the intellectual property and all the R&D that we have developed so far. And in terms of the prospective markets, we intend to introduce the PAPR this year with an initial target of 1,000 units at a target price of 30,000 rupees for an annual revenue of 3 crores. And then subsequently in year 2, we expect to introduce the PAPR and the ventilator. So sort of modest entry targets for the ventilator, about 1,000 units, with a target price about revenues of 60 crores. And the PAPR, we expect to increase by about 10 times. Here's a quick look at the various revisions of our ventilator, going from the very basics to the current version, which is very lightweight and well designed. Here's a quick look at our team, consisting of our India and US partners. 2 of our main team has a lot of experience in the USA. One has 30 plus years of experience in medical devices. Another one has hands-on experience with QA and worked on medical devices in the Silicon Valley and has moved back to India. And our various collaborators, we have a medical advisor in the UK and several senior members. Here is our partnerships, Bio Valley at Andhra Pradesh Medical Technology Zone. Thank you very much for listening to our story. And if anybody wishes to contact us, you can reach me on the email or on the telephone number listed here.
Thank you so much, Tulsi, and all the very best to Team Foundry. Next up, we had our third part of the cohort, Innovo Idea. Can we have the team Innovo Idea on the stage, please?
Good evening, everyone. I'm Pooja Saxena, founder for Infinity 8. Innovo Idea was my previous company where I used to work. So the venture that I am launching here is Infinity 8. And me being into the training and capacity building sector for past 2 decades, have worked in the space of hospital safety, industrial safety, and road safety. So before I start with my product and range that we would be serving. I would just like to tell you a bit about my journey. So, being into the training and capacity building sector, I realized that we do not have properly designed equipments and survival kits, and whenever we used to go for mock drills, whenever we used to go for any kind of demo exercise, we had a dearth of equipment. So, right, on a global scale or on a country national scale, we did not have people who would be designing and manufacturing the kind of equipment that were needed for assessing mock drills or for conducting mock drills, whether it's in hospital space, industrial space, or even in road safety. So that is when we realized that even under the guidelines given from the National Disaster Management Authority, and also with the kind of stress that the government has on disaster management and preparedness, we were not able to conduct the kind of mock drills and exercises that we ought to, and bring the kind of impact that we wanted to. So that is when I realized that I need to branch out and do something about this sector and come into the manufacturing. So already having the strength of training and capacity building people on board, and having for the length and breadth of the country, I thought that I should venture into manufacturing of kits. And the very first product that we are coming out with is the CPR mannequin. It's a very simple product, but still, if you see within the country, we either find a lot of Chinese goods, or we find very expensive brands which are European and US owned. And if we talk about Indian, we have very less, hardly 2 or 3 companies in the whole of the country who's making CPR mannequins. But with the sudden pre-COVID and post-COVID also, if you see the kind of sudden cardiac arrest that the country has been, witnessing, and we losing our very important people and even people next door to this. So I think CPR is one skill that we all should, imbibe, and community resilience should come through CPR. So that is why this very first product of mine, the CPR mannequin. So the presentation will take you through what we thought about. So Infinity 8, it's a very young company. We just got registered on 10th April, and thanks to Dr. Naveen for believing in us and giving us this huge platform to take our dreams through. So we would like to bring all our technical expertise in designing, and bringing those rare kits, and having very targeted kits for each of the, whether it's mass casualty management, whether it's triage, or whether any kind of preparedness and resilience codes that we need to design. So a vision of Infinity 8 is to make India resilient, safe, smarter, for our people to know the basic skills of how to treat people next door, how to even save lives in their own houses. So our mission of Infinity 8 is to bring innovative solutions within the bandwidth of preparedness. We want to, the previous, the first cohort member was, they were talking about how to, take care of patients who have already gone through the heart attack, and we are basically talking about how to save lives when it's happening. So we are very, close to this sudden cardiac arrest diseases that we want to. So right from any kind of, hazards that the community face. Okay, so this is a very small team we are starting with. Myself, I've already introduced. My partner is Sakina, and she is into product, development. She is based out of Surat, and I'm based out of Delhi. So we are working here, and we do have a small team of senior biomedical engineer and a first aid expert, Mr. Vivek Thakur. He himself has an experience of almost more than 2 decades into first aid. So CPR mannequin, the product that we have, what we are trying to do is we are trying to bring the technique of how to perform CPR along with the product. So what I'm trying to do is I'm trying to perform a marriage between the two. Since I already have a network of training, people who could go and train. So I am coming out with manufacturing capacities in planning to do it in Gujarat or in in Haryana, so that we are able to manufacture these low cost environment friendly CPR mannequins, which can be given out while CPR training is being conducted, so that once we conduct a training, we also hand over the CPR mannequins. It is easily available so that everybody could learn the CPR skill. That is what the aim of Infinity 8 is. Now, I don't need to talk about the importance of CPR training. As you all know, CPR training, it is very important, and we have, in the previous few years, we have seen how important it is. If we could have saved a lot of lives with that, we couldn't. So the benefits of my CPR mannequin, which we are designing, is basically it will have a small feedback system, so that it will give you the amount of pressure that you're exerting while learning the skill. It will also teach you the kind of accuracy in terms of putting the pressure. It will be a self-guided training, so that once the master trainers or once our person goes in and trains the person, then the next lot can be trained by the people who are trained by us. So that will get the cascading effect for the CPR training. And of course, we could also look into the motivation factor, because you could do it yourself. That motivates within the family or in an organization or in any society to take the CPR skills. So these are the components of the mannequin, of course. So the problem definition of our product is, as we spoke about, is to arrest the cardiac arrest, to give then and there support whenever it is needed, to make the community more resilient, that they learn the skill and are able to practice it. We are looking at 3 types of CPR mannequins. First is the basic feedback model, which I just showcased. The second one we have researched and designed is that we could also, because there's a lot of hollow space within the CPR mannequin, so what we are trying to do is also have a medical kit within the CPR mannequin, which would address almost 17 emergencies if need be. So that is the second model, and the third model would consist of a voice assistant. So what we are trying to do is we are trying to, through Indian languages, 11 Indian languages, and through the voice assistant, we are going to feed in 53 emergency responses within the CPR mannequin. As I was also a part of the Ministry of Education First Aid module, which has been implemented by the Ministry of Education under the FAST app. So we have the rights of the National Disaster Management Authority First Aid module, which is already approved. So the same module we are going to we are going to change it into a voice assistant, and we'll be catering to 11 Indian languages from all over the country. So these are the 3 models that we are planning to undertake. So of course, applications of CPR mannequin, we know it's a community-wide, whether it's schools, colleges, any organizations, any kind of social forum, we need to have CPR skills. Right now, we are in the phase of evidence generation has already been attained. We have already commenced designing. We are almost 90% designing has been completed. We are just in the phase of 10% of designing is left in terms of the face and IPR, and all those things are left. The rest we have already completed. So we are also in the works of marketing strategy and product launch. That is where we would be seeking support from Dr. Naveen to assist us to take us further. This is the product pathway that we have been following, so right from ideation stage to the clinical study to design engineering. And right now also we are looking very closely that we are not going to use the material which is because anything which wherever we use material which is costly, So it will really the cost go way up. So we are looking at low cost, we're looking at environment friendly materials. So that is why for past 40-45 days we have been researching with various technical experts on the kind of material we will be using, which is biodegradable as well as low cost and can be replicated faster. And we do have manufacturers of that material within the country, so that we're able to make a product which is made with the raw material available in the country. So that's what we're trying to do. These are the leading key players which are in the segment. If you see Ambu, Gomod, Nasco, Lateral. So these are the key players. And if you see at the market, of course, the market for the, global market for medical devices is booming. And we have spoken about, the medical devices market in the country, which is also being, day by day, it's being, it's being pushed by the government and as well as by the medical fraternity itself. And if you, these are some numbers of the medical devices market that are available. So, if you look at the numbers of TAM, SAM, and SOM, you will also see that there is a lot of need to be picked up. A lot of things can come out under the market. So here, I would like to say the CPR mannequin is just one product that we would be going in. After that, there are a range of products like the bystander kits. We talk about mass casualty management kits. We talk about mock drill kits for industrial safety. So a lot of kits need to be designed and manufactured. Yeah, this is some kind of market competitors. We have done some survey, and if you see the kind of price range, so we are planning to come up with our CPR mannequin which is below 5,000. That is what the aim is for the basic CPR mannequin which has a feedback system. And even for the highest range, we are looking to come between 10,000, because the main impact will come only when we are cheaper. So that is what we are trying to attain, is to make a cost-effective CPR mannequin which can be available for the masses. Yeah, so that's Infinity 8. That's what we're trying to do. That's what the problem we're trying to solve. Thank you.
Hi, it's a wonderful presentation and congratulations. I just wanted to know if somebody wants to just take this, say, to an RWA or just to educate, say, in a school or anything like that. So we purchase this and then you do a training. And is that when your trainers are out, or how does that work? Like, is it is it a refresher training? Do we pay for a training? How does that work? Like, I just want to understand that.
Yeah, so the offer that we have coined right now within our organization is, we are trying to do for a day, for a CPR AED combined package. We are trying to for 30,000. We will be teaching a master trainers batch of 30 people, and we will also be giving out a CPR mannequin within it. So that is what, so that those master trainers within the RWA, when they become capable of skillful of doing that, then they can further cascade the training themselves. So we don't need to be there then. So that is what we are trying to do. So it is, if you compare the AHA and other training streams and BLS training that are available in the market, this is very cheap. It's just 1,000 rupees per person. So that's what we are trying to do, the mass scale in this. I hope I've answered.
So when difficult time comes, most of the founders, give up. If they are not liking, if they are not having passion or obsession, I would say, So what was that story? Why did you choose this only?
Yeah, thank you for asking this question.
And it was a good presentation and good subject which you have chosen. So let me congratulate you for that as well.
Thank you, sir. Thank you. Yes, sir. So the thing is that, as I've mentioned to you, that for past 2 decades I've been in training and capacity building. So whenever we would design a training for, whether it's ONGC, GAIL, RWA, NDMA, SDMA, DDM, anything, we would end up getting the act together, whether it is gas leakage training, mass casualty management training, industrial safety training, anything. There were no kits in the market for everything. We would need to get everything together, and it would be a huge cost. And then if we tell them ki aap mock drill karo, 6 mahine mein karo, there is an act, there is a policy, but then there is no equipment. People will not be able to do it. Even triage kits are not not there. So nobody knows, even if we tell them how to do it, they cannot replicate. So that is where I felt that whole gap, that whatever we are teaching to them, whatever we are telling them, they cannot replicate because there is absolutely no equipment available. So that is why I ventured out and I said that I should go into manufacturing because I have the technical know-how. We as a company have an institutional knowledge, but there are no players in this whole genre. So that is where.
Good, keep it up. Yeah.
Thank you. That's...
I think, good evening, I'm Dr. Kaur this side. I think I have no questions to be asking. I think I'd like to talk about congratulating the Voice of Healthcare team and Dr. Naveen for bringing a very important kind of thing. I think around for the VOH Incubator. I'd like to add, we had the last panel discussion. We heard, I think Berman was there, and he talked about गम की बारिश है तो अकेले खड़े थे, और जब actual बारिश आई तो there was a lot of भीड़. I think this is where I think the Voice of Health Incubator Club probably fit in. Like an umbrella. When you're all alone and standing, I think it keeps you shape, and you stand underneath with all the ribs of the mentors. And this is what it protects you from various onslaughts, harshness, and probably take you forward. And stay bounded by the stem, and it'll take you forward. Now, when it comes to the actual rain, because it still says you maintain your identity, otherwise you'll be lost in the crowd. I think that's a wonderful initiative. Congratulations once again, and
Thank you.
Thank you so much.
Thank you, sir. Thank you, Dr. Gaur. Vinayak, Dr. Gaur just quoted your shairi that you did, so you just came in late. You heard it. Great. So we are done with the presentations. Once again, all the best to all of our first members of cohort. Moving on, let's officially again launch the VOH Incubator by calling up the dignitaries up on the stage. I'd like to call upon Dr. Naveen Nischal, Mr. Sanjay Jha, Tarun Agarwal, Mr. Manu Bhandari, Vinayak Barman, Ms. Alka Goyal, Dr. Mansi Agarwal, Mr. Rajiv Nath, Dr. Ashish Chaudhary. If you're around, please come up on the stage. Dr. Ravi Gaur, Mr. Prakash Sharma, Dr. Anil Bhola, Mr. Vikram Anand, Mr. Rakesh Sharma, Dr. Sarika Gupta, Mr. Jatin Mahajan. Can we please have all of you all on the stage? And I think we are ready for the official launch. Dr. Sarika. Yes. Sir, wait for Dr. Sarika. She's coming. Dr. Dinesh Batra, if you're around, please come up. And our incubators as well. Please come up on the stage, Team Foundry, Team Semper Centrum, and Team Innovate. Thank you so much, everyone, for being here with us today. We are so grateful to be sharing this special occasion with you all. I'm sure all the delegates, event partners, incubator members, and our mentors, advisors had an interesting and informative discussions today. So would not like to take any further time from you all and would like to request everybody to please proceed with the networking reception that's set outside. Thank you so much.